I'll continue in English, but like if you have any questions or if you need to explain in Sinhala, please let me know on there. And if you have any questions, just stop me right there and ask me. And I'm joining from my home. So if the connection is gone somewhere out of nowhere, please let me know on there. So today we are doing the respiratory system, RS MCQs in pediatrics. So I'll try to, while on discussing, I'll try to remember a little bit about theory around the area as well before moving into another question. So the first one is uh, 2012 regarding pneumonia. A mycoplasma pneumonia causes extrapulmonary manifestations. Now, when it comes to mycoplasma, now we know that like for pneumonia, there are like a lot of organisms involved. You have the typical and the atypical ones, and mycoplasma comes under the atypicals. When it comes to mycoplasma, nice to know that it has lot of manifestations just other than the respiratory system. Now the stem wise, it's already obvious. It's the stem is true, but the things that we need to know a little bit about what are the extrapulmonary manifestations of mycoplasma. Now, for this module on, yeah, yeah, hello. Connection is chukta kaud. May I'll see. Hello. May connection. Madin. Hmm? Hello. Yeah. May ane teacher mamu hai. Oh, එහෙමද අනේ මචං මං ගෙදර ඉඳන් ජොයින් වෙන්න අර සිග්නල් තාම එච්චරම හරි නැහැ. මේ එහෙම වුණොත් මට චුට්ටක් කලින් කියනවද මේ කියන්නේ මේගෙන එනකොට මට එතකොට ආපහු කන්ටිනියු කරන්න පුළුවන්. තාම තියෙනවද ඒක? ඔව්. දැන් ෂේප් නේ. හරි මේ මොකක් හරි තිබ්බොත් අනේ මට චුට්ටක් කියන්න මේ හරි. මොකද මේ ගෙදර ඉඳන් මං ජොයින් වෙන්නේ සිග්නල් තාම මෙහාට එච්චරම හරි නැහැ. Hari. Okay, so when it comes to mycoplasma, it kind of affect or very different systems, and it's nice to know what the types of extrapulmonary manifestations are. One thing is hematological. Uh, Now, mycoplasma causes autoimmune hemolytic, IHA, also ITP and disseminated intravascular coagulation. Then it can go and affect the skin. Steven Johnson syndrome, then erythema nodosum and erythema multiforme all can cause by mycoplasma. Then GI wise, it can cause chronic diarrhea and pancreatitis and GI wise. And neurologically, it can go and mycoplasma can cause aseptic meningitis, one thing, and the other thing, Guillain-Barré syndrome or meningoencephalitis and transverse myelitis. Likewise, there are like different manifestations of mycoplasma, and also this thing. things. In CVS, it can cause myocarditis. Just not the myocarditis, the entire heart, the pericarditis, endocarditis, myocarditis, and even the heart failure. So likewise, this mycoplasma has can go and affect almost all the systems in different ways, and then generalized lymph nodes, splenomegaly. Renal wise, it can cause glomerular nephritis and interstitial nephritis. So likewise, it can go and affect anywhere. And there's a small table. If you can, if you, I'll go. I'll send the guideline later, because guideline there's a Sri Lankan guideline specifically made for respiratory tract in a small table. It's better to know in MCQ. Manifestation virus is the when it comes to the etiological factors of pneumonia. It can be it's like this. When it comes to the age wise, if the children are less than 5 years, then the viruses are actually the most commonest one. But that's not the case for children above 5 years. Then the bacteria comes in the to the top, and out of the bacteria also the streptococcus is the most commonest one. So virus is not the commonest etiology for children more than 5 years. Anyway, about in 30% of pneumonias, there the etiology can be mixed, as well as only about, even if the bacteria, sometimes even if we take a blood culture, it only get positive only about in 10%. So that's why you most of the times, if it is a pneumonia, choose to give the choice of treatment is an antibiotic, because we can't exactly say it's a bacteria or a virus, and there can be about in 30% it can be mixed. When it comes to the age-wise etiologies, in children less than 5 years, viruses are the most common ones, and after that, above 5 years, bacteria comes to the top. So, as a statement, this statement is wrong. And when it comes to bacteria as well, in this community acquired pneumonias, the age group is different. The etiological organisms for different age groups are different. When it comes to like uh, all the children, you can see this mycoplasma, streptococcus, and chlamydia, and viruses are actually not very common when it comes to all the children. Then C. Staphylococcus pneumonia is associated with metastatic abscesses. This is true. Specifically, these metastatic abscesses are usually occur due to the hematogenous spread from, that means, if we take the primary focus, that's the lung, but after that they can get disseminated through the bloodstream and go somewhere else. So when it comes to metastatic abscess formation, they can go and disseminate into the liver, lungs, or brain abscesses. Likewise, there are several organisms that can usually known to cause metastatic abscesses. metastatic abscesses or can cause disseminated abscess formation in multiple foci. One is notoriously known one is Staphylococcus, and actually that's the most common ones. Especially the MRSAs are known to cause MRSA positive staphylococcal pneumonia known to cause they can cause endocarditis. When it comes to gram-negative organisms, Klebsiella is known to cause metastatic abscess formation. Especially these, there's an overlap between this abscess formations and cavitating pneumonia causing organisms. Now, the cavitating pneumonia is also usually caused by Staphylococcus, Klebsiella, and melioidosis. So, those are the main organisms that can cause the Staphylococcus pneumonia. They form they start to form in the lung parenchyma as well as thrombosis in the intrapulmonary vessels, and actually that leads to a gang. So these symptoms that I mentioned already, streptococcus, staphylococcus, especially MRSA positive. From the gram negative organisms, Klebsiella is known to cause invasive disease, and other one is melioidosis. It's not a very common thing to present. It's not a very common etiology for pneumonia per se, but melioidosis can present with, anyway, the feature of the melioidosis is abscess formation, and it also can present with pneumonia. Then stem E, Haemophilus influenza infection commonly leads to pneumatoceles. Now, when it comes to pneumonia, it's nice to know a little bit about what we call the complications of pneumonia. So there are local and systemic complications. The local complications that we see is usually we suspect these complications when the pneumonia is not resolving properly. If it is not, if it's either poorly responding, and if the antibiotic regimen is made sure that is given properly, the route is properly given, the dose regimens, everything is proper, but still it's not resolving, we kind of expect complications. So when it comes to these local complications, the common ones are pleural effusion, parapneumonic effusions, and if it goes into the further in an empyema, pus collections, then lung abscess formation, and if the pneumonia has gone into a necrotizing pneumonia, and then those are the local complications, and out of this pneumatocele formation is what happens is there are air filled cavity formation. Usually this occurs alongside with as a sequelae of if we get a cavitatory pneumonia, especially with the organisms that I mentioned above, Staphylococcus, Streptococcus, Klebsiella. These cause cavity formation, and once the cavity is resolving, they can produce these air-filled spaces, and that's what we call the pneumatocele. So, pneumatocele formation is usually known to cause with Staphylococcus, Streptococcus, and Klebsiella. Those are the organisms which are known to cause this pneumatocele formation. Haemophilus influenza is actually not an organism known to cause uh, not an organism known to cause pneumatococcus. So that's a false statement. So in this particular question, mycoplasma causes extrapulmonary manifestations. That's true. Virus is the commonest etiology for children more than 5 years. That's false. Actually, that's commonest etiology for children less than 5 years. Staphylococcus pneumonia is associated with metastatic abscesses. That's true. Strep pneumonia leads to invasive disease. True. Haemophilus influenza infection commonly leads to pneumatococcus. That's wrong. So, any questions? Okay, if you have any questions, please ask only at any time. So that's the regarding the stem for the true false question. Then that's regarding the pneumonia actually. So basically, when it comes to pneumonia, we need to know a little bit about the etiological factors and then the etiological agents usually. Like the types of pneumonias they can cause, and at sometimes they ask about the specific complications of the pneumonia, especially this Staph aureus and streptococcal pneumonias can go and cause necrotizing pneumonias, invasive disease, and many complications. Mycoplasma is usually common in school age children. Yeah, usually the about like 5 to 10 years, it's usually common at that age, and they can have different extrapulmonary manifestations. After that, a little bit about assessing the severity of the pneumonia, like the criteria that is used in children. We use this temperature, respiratory rate, recessions, and feeding, and after that the antibiotic choice, and a little bit about the complications. Those are the things mainly they are questioning on. Uh, so the next question is, this is an SBA. A child presented with stridor while crying since 3 weeks of birth. His feeding is satisfactory. No other abnormalities detected on examination except for an inspiratory stridor. Most appropriate management option: A. Make arrangements for microlaryngoscopy, nebulized with budesonide. C. Reassure the mother, nebulize with dexamethasone. Arrange lateral neck X-ray. So, in as a general principle, in any question, like if a child is coming with very early symptoms, especially starting either from the birth or in immediate neonatal period, the diagnosis set usually narrow down to a particular set of especially particular set of diagnosis, like usually the congenital diseases. Those things come to first as a general rule in especially in PAED usually, because in PAED the thing is, when we think about the diagnosis, usually it has to tally with the age, particular age. Now, when we consider stridor, usually it's stridor is where the things that we usually see in stridor, like the mostly stress points are either viral group or acute epiglottitis. But the thing is that a stridor can be due to many causes. It could be a foreign body aspiration, anaphylaxis, flu, then epiglottitis, congenital malformations, trauma. So any of these things can cause stridor. So when it comes to a very young child with stridor while crying since birth, uh, since 3 weeks of birth, rather than this viral group or epiglottitis, what comes to the top is congenital causes. Now, when we consider about chronic stridor, now since we don't know the exact time period this child is having the symptoms, it has started at the 3 weeks of birth. So, what comes to the top of the diagnosis list is some sort of a structural problem. It could be either some kind of internal narrowing, or sometimes maybe a laryngotracheal airway may be collapsed. So, in that case, what comes to the top is either laryngomalacia with a what we call a floppy larynx. It causes a very soft and immature cartilage of the upper larynx, and it causes collapsing on the inspiration. Due to the very soft nature of the laryngeal cartilages, it collapses on inspiration and it gives rise to an inspiratory stridor. It's a congenital anomaly. However, the thing is, it presents at around the 4 weeks of age, because the thing is, as at the very beginning, the respiration is is respiration or the respiratory flow rate of the air columns are not very sufficient to generate a stridor. There are the inspiratory columns are not powerful enough to generate a audible stridor. So once the respiration matures with the age, at around 4 weeks of from birth, they start to get this inspiratory stridor. And usually it worsens with when the child is crying or when he's agitated or maybe even feeding. When they exert a more effort on the respiration, this stridor become more prominent. But the thing is, usually this laryngeal laryngomalacia, it doesn't cause any problem to the child unless usually child's growth is normal, the feeding is satisfactory, and if the child is also thriving, actually there is no any other treatment is required for laryngomalacia. We can just reassure, and usually there's no need of any other investigation, and it usually resolves by 2 years of age. So that's the usual cause of laryngomalacia. That's the usual picture of laryngomalacia. And the other problems, the congenital problems that can present with a stride or upper airway obstruction are one thing, glottic stenosis, or maybe an external compression due to a lymph node or tumor, or maybe a vascular ring causing compression. So those things are the other congenital malformations or problems that can present with the with stridor in an infant. Uh, so in this case, now a child presents with stridor while crying since 3 weeks of birth, which is very typical picture, typical story of a child with what we call laryngomalacia. And feeding is satisfactory. No other abnormalities are detected on examination except for an inspiratory stridor. Most appropriate management option. A. Make arrangement for microlaryngoscopy. B. Nebulize with budesonide. Reassure mother. Nebulize with dexamethasone. Arrange lateral neck X-ray. So out of this, now in a typical story of laryngomalacia, which is very similar to this, we don't need unless the child is thriving, he's feeding well. There are no any other concerning features on examination like significant distress, cyanosis, those things. We don't need to go for a further investigation. No any treatment. Usually, it's self-limiting and resolves around 2 years of age. So the most appropriate management for this particular child will be reassuring mother. The thing, since it's not anything inflammatory, there's no use of steroid nebulization to reduce inflammation or anything, because there's nothing involved with an inflammation. And this microlaryngoscopy and other X-ray investigations are usually reserved if the child is not thriving, if the weight gain is poor, if the feeding is not good, and if he shows any signs of like cyanosis. At those points we need to consider usually this microlaryngoscopy and lateral neck x-rays usually considered if there's a suspicion of a laryngeal retropharyngeal abscess or something. So unless in this child there are nothing, no red what we call this uh, problematic signs or problematic features. So at this stage, there's no necessity of use of these investigations or nebulizations. Just the reassurance is enough. So in a the key point is if a child usually presents with symptoms from since birth, and usually in a presentation like stridor, we have to think about conditions other than this laryngotracheobronchitis and epiglottitis, and we have to focus on a little bit about possibilities of a congenital problems, one thing. And when it comes to laryngomalacia, the typical picture is it's usually starts after birth, around 3 to 4 weeks of birth. It's an inspiratory stridor. Usually, it worsens on exertion like crying, agitation, feeding, or lying on back. And uh, examination wise, usually everything is normal except for the stridor. And the management wise, it's usually self limiting and there's nothing to do. The investigations are reserved for children with warning signs, especially if they are not feeding properly, if the weight gain is poor, they are not thriving, and if there are some signs of respiratory distress or anything, at that point, investigations might be considered. Otherwise, usually for this particular child, just reassurance is enough. Any questions? මේ කාට හරි questions තියෙනවද කියලා. මේ අන කාට හරි සිංහලෙන් කියන්න ඕන නම් චුට්ටක් කියන්න හොඳේ. ඊළඟට the next question. A 7-year-old girl presented with an acute attack of wheezing, nebulized 2 times with salbutamol within last 1 hour in OPD. On admission, respiratory rate is 50 per minute, heart rate is 110, air entry equal, vesicular breathing with prolonged expiration. SPO saturation is 94. The next step of management: A. Commence magnesium sulfate infusion. B. Commence aminophylline. C. Oxygen via face mask. Nebulize with ipratropium. And repeat salbutamol nebulization. So, a- acute exacerbations of asthma is something that usually, like, every day, every time they question at some point. So it's nice to know, like, in and out of asthma. One thing, the stepwise management, the other thing is acute exacerbation. So acute exacerbations of asthma, first of all, it's a life threatening emergency, and usually asthma is very straightforward, and there are sometimes there may be alternative diagnosis. So alternative diagnosis should be considered if, like, if there's fever and tachypnea without wheezing, not much of wheezing, then usually fever and tachypnea is a tachypneic, being tachypneic is a sign of pneumonia. So at that point, pneumonia should be considered. And if it's a stridor, uh, it's group O epiglottitis, those things come. So if the lung signs are asymmetric, and if a child comes with either stridor or wheezing, something that should never be missed is foreign body aspirations, and even anaphylaxis also can present with wheezing. So those are the other causes of wheezing, acute episodes of wheezing. But in this type of a question, it's pretty obvious. They have mentioned like acute attack of wheezing, so there's nothing to diagnose. So the another thing that need to know or remember is the what we call severity assessment in acute severe asthma, acute asthma exacerbation. So the things that we consider is the mental status or the conscious level. Then we consider the speech, whether the child is able to speak in no difficulty, speaking in sentences, phrases, or poorly responding. Then cyanosis, whether it's present or absent, pulse rate, respiratory rate, recessions, accessory muscles, auscultation, and saturation. So those things are the things that we consider. So based on that, we divide it into mild, moderate, severe, and life threatening. Now, usually in the mild form, usually everything is normal and almost just the wheezing is there. Otherwise, there's nothing abnormal. Consciousness level is normal, speech is normal. There's no cyanosis, pulse rate, respirate rate, everything is normal for the age. Just the only thing is wheezing. In a moderate attack, usually what happens is then the pulse rate increase, respirate rate increase. There's some use of accessory muscles and chest wall recessions are there to some level. Auscultation is also still the air entry is good and there's some amount of wheezing and saturation is also still good. In the severe form, the child is either restless or agitated, and they can't speak in like complete sentences. Too breathless. Usually, they use small phrases to talk, and still now the pulse rate has been increased, respiratory rate increased. Accessory muscles and chest wall recessions, effort, the workload for respiration is increased than the moderate attack, it's severe. And on auscultation, now the uh, bronchospasms are so severe to the point air entry is reduced. That's just one feature to differentiate from a moderate episode, a reduced air entry. And the saturation is also low. So in a life-threatening one, all the parameters are reduced, all the parameters are deteriorated, and at that point, cyanosis is present. And what we call is silent chest is there. No longer the respiratory effort is too poor to have any respiratory recessions and chest wall recessions or accessory muscle use. Everything is reduced. Just at that point, the chest is almost silent. So that's how we grade this depending on the what we call clinical parameters. So in this one, respiratory rate is for a 7-year-old 50 is increased definitely, because the normal respiratory rate for a 7-year-old around 20 to 25. 50 is definitely very high. Heart rate is also heart rate for 7-year-old actually this is pretty normal. Air entry equal, vesicular breathing with prolonged expiration, and SpO2 is also normal. So that is more to the moderate side, moderate exacerbation, but moderate to severe. So she has been nebulized 2 times with salbutamol within the last hour. So when it comes to management in a mild attack, usually we can manage at a OPD setting. So we just give the use the meter dose inhalers that we usually give for the children and with the inhaled short acting bronchodilators through an inhaler, but we increase the dose actually. Usually we give 2 to 6 puff or and then we repeat it continuously. In the absence of an inhaled bronchodilator, we can use an oral bronchodilator, and after that, medications are prescribed for another about a week, 5 to 7 days. So that's for the mild attack. For a moderate attack, initial management is starts with inhaled short-acting beta-2 receptor agonist salbutamol with the space and a mask, and we at that point we actually give 10 puffs. ඔක චතුරංගන සර් ලස්සනට කියනවා මේ ඔය OPD setting එකදී අර ළමයින්ට ඇඩ්වයිස් කරන්න ඕන විදිහ. මේ අර තියෙන ඉන්හේලර් එකම පප් 10ක් මේ ඇදලා බලන්න කියලා ගෙදරදී අරන් එනකම්. ඊට පස්සේ the if the meter dose inhalers are not very available or can't find or it's not responsive, then we go for a nebulized salbutamol, 2.5 milligram or for less than 5 years and more than 5 milligrams for more than 5 years with normal saline and with oxygen. Then we give oral steroids, prednisolone, for 3 days. And if the saturation is only less than 9 to 2 after the initial bronchodilators, then the child need an admission. So that's how uh, a moderate episode goes. Just with we can either manage with uh, meter dose inhaler meter dose inhalers of meter dose inhalers and bronchodilators, or we can go for a nebulization. So those two, and followed by oral prednisolone, oral steroids for another 3 days, and admission is required if the child is persistently desaturated or the response is poor. Then it comes the usually question problem, acute severe exacerbation. So in an acute severe exacerbation, what we do is first thing, one thing, oxygen, and then monitoring. Oxygen driven nebulization is given. Nebulization you should always accompanied with oxygen. At that point, we give the salbutamol 2.5 milligrams for children less than 5 years and 5 milligrams for more than 5 years, and with ipratropium and normal saline, and we go back to back nebulizations for 3 times over 1 hour. Then it should be followed with iv hydrocortisone uh, or it can, if the child can orally tolerate, we can go by oral prednisolone and magnesium sulfate. If it is still not responding, we can go for IV salbutamol and salbutamol, IV aminophylline, those things. But at that point, child is not managed at a normal ward setting or an PTU setting. The child should be ideally admitted to a ICU. Also, for a the investigations that should be considered are, one thing, chest X-ray. One thing that we need to exclude is a pneumothorax, or other thing is a pneumonia. So chest X-ray and blood gas analysis is usually considered, because if the respiratory effort is start to deteriorate, there's a risk of impending respiratory paralysis. So if the carbon dioxide levels are going up in what we call the blood gas analysis, that's an early indicate impending respiratory muscle paralysis, type 2 respiratory failure. So those are the uh, investigations that considered in a child with poor response to treatment in acute severe asthma. And other things are like, at an ICU setting, IV fluids, ketamine, and intubation and ventilation due to respiratory muscle paralysis. Those things are like the final steps of acute severe management. The early steps that we need to know is, one thing, oxygen, continuous monitoring, nebulization with oxygen, salbutamol, ipratropium with oxygen, back to back 3 times over 1 hour. Then IV hydrocortisone 4 milligrams per kilogram, or if they can retain orally, we can give prednisolone. The efficacy wise, there's nothing different. That depends on whether the child is able to tolerate. Then if it is not IV magnesium sulfate, then if it is still not responding, uh, we have the child should be ideally admitted to an ICU. Can use IV salbutamol, IV aminophylline, and other considerations like chest X-rays, ABGs, uh, ketamine and paralysis and intubation, those things, and sedation, those things are considered at that point. So in this child, on the respiratory rate is 50, heart rate is 110. And this 110 is, it's not a very consistent feature with an acute exacerbation of asthma. Usually 110 is normal for a 7-year girl. There's a table in the asthma guideline which shows this this age appropriate heart rate and those things. Definitely, this 50 is a 50 is increased for a 7 year old. Usually, 50 is even not normal for a 1 year old. Usually, they also respiratory rate goes maximum up to 40. 30 to 40 is the normal range. 50 is still high for them even, definitely high for a 7 year old. The heart rate is a bit tricky here because that up to 120 it could be normal. Air entry is equal. Vesicular breathing, prolonged expiration. So still they have, still she still she has not exactly responded as well. SpO2 is 94. That's actually good. Then the next step of management wise, we can consider she has nebulized 2 times now. So one thing special, if she is coming to an OPD like this, to a ward like this, one thing we have to start her on the oxygen, and the other thing is we can actually repeat nebulization again about for 3 times, and then we can go for either hydrocortisone or prednisolone with steroids, and then magnesium sulfate. Then after that, ICU admission and IV salbutamol, IV aminophylline, sedation, those things come. So for this one, the next step of management is, uh, for this one, we can repeat the salbutamol nebulization and see. That's the answer. I think we can go for this one. Yeah. The question is not very obvious because the problem is the parameters are all over the place. Don't add up really. Yeah, entry is equal. Yeah, we can go with the salbutamol nebulization for the next step. The SpO2 is also 94 no. So rather than even oxygen, we can go with this one. Okay. Then the next one. A 4-year-old girl is being investigated for bronchiectasis. So, which of the following is of significance to etiology? So, bronchiectasis in a child, usually always there's some form of underlying pathology. So, if a child is coming with bronchiectasis, if a child is diagnosed to have bronchiectasis, definitely there's some sort of underlying pathologies there. So, as in an adult, also the bronchiectasis is su- suspected when a child is having like prolonged wet cough for a long time, and especially if the child is having unresolving pneumonias or recurrent pneumonias. Also, at that point, we consider bronchiectasis as a diagnosis. So, when the hallmark feature of bronchiectasis is irreversible dilation of airways, and that usually occurs as a result of what we call it repeated the pathogenesis is we have like repeated chest infections going on, and there's some sort of an obstruction as well, so that go into almost like a vicious cycle, and it end up in a always the airways are getting inflamed, and then they go into the hyperplasia and those things, and fire airway remodeling, and they finally end up in irreversible dilation. So usually in a child we consider bronchiectasis if a child is having productive or moist cough almost daily for about 8 weeks without a period of remission. without going into a resolution, if the persistent cough is there, one thing in our setting that we consider is TB, obviously. The other thing we need to consider bronchiectasis. Another place this bronchiectasis that we consider as a diagnosis is when a child is having poorly resolving asthma or difficult to control asthma. In that case, also, despite even if the child is on a bronchodilator therapy adequately, but still the child is not having a proper resolution of symptoms, symptom control, then as we consider bronchiectasis. And if the prolonged cough even more than like for 3 weeks with worsening symptoms, and if a if a child is having pneumonia and they are not going into a complete resolution, and the physical signs and the persistent radiological changes are there even after an episode of a severe asthma, recurrent pneumonia like 2 episodes of pneumonia within 12 months of periods. If a child is having a chest deformity, there are signs of chronic inflammation or chronic disease like finger clubbing, uh, and failure to thrive. So those things at that point we usually consider bronchiectasis as a diagnosis. So to diagnose bronchiectasis, the definitive diagnosis, one thing we do a chest X-ray as a baseline. This prominent bronchovascular markings, dilated bronchi, uh, peribronchial thickened bronchioles. So these things are seen in a chest X-ray, and definitive diagnosis is done with an HRCT. So what's important is in a child, there are different causes of usually there's an underlying cause for bronchiectasis. One thing that is if it's a coming after, sometimes it can present after some sort of a severe pneumonia, and then following that incomplete resolution and incomplete resolution can go into a state of bronchiectasis. Then another one is if a child is having an immunodeficiency. So immunodeficiency syndromes usually come with multiple recurrent pneumonia, multiple other infections, not just the pneumonia. In immunodeficiency, children present with multiple repetitive ear infections, skin rashes, and if sometimes children come with recurrent abscess formations. So in that case we have the we it's pointed towards a immunodeficiency disorders. Then sometimes they can come with aspiration syndromes. If there's a history of like cough, recurrent choking with feeds, and recurrent vomiting, regurgitation. So and if there's a history of some sort of a neurological disease in a child, so that points towards an aspiration syndrome. Another one is what can happen is accidental foreign body inhalation, but uh, it goes missing somewhere in the lung parenchyma, in the tracheobronchial tree somewhere, and then it causes a permanent obstruction there, and that causes some focal bronchiectasis. Especially the in a this missed foreign bodies also can present with bronchiectasis, but in that case usually the bronchiectasis is a focal one, limited to a one particular lobe or something, not a disseminated bronchiectasis. uh, if that's the case, usually child might have a history of a foreign body aspiration or something, some episode of sudden onset of wheezing or choking or stridor, those kind of episode might be there, but sometimes it might go unnoticed as well. Then another diagnosis that we need to consider here is what we that is if specifically a child is coming with very badly controlled asthma despite on multiple treatments, and if the parents are telling no, the child is adherent to the treatment, and on examination also actually the technique is good and everything is perfectly fine in the treatment wise, but still the child is not responding and the asthma is very poorly controlled, we consider this bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis also can cause bronchiectasis. And one important thing is we need to know is cystic fibrosis and primary ciliary dyskinesia. In cystic fibrosis, also due this primary ciliary dyskinesia and cystic fibrosis also they can present with bronchiectasis. In that case, usually there's a history of in primary ciliary dyskinesia. You can get like this history of some sort of neonatal respiratory distress, particularly in a term baby, and delay like prolonged wet cough since like early childhood, early infancy, and recurrent ear infections. Mm, and persistent sinusitis. So, and congenital heart defects. They can have this congenital heart disease and situs abnormality. This dextrocardia and situs inversus. Those things can be there in primary ciliary dyskinesia. In cystic fibrosis, also due to this uh, cystic fibrosis also can manifest with bronchiectasis. So, cystic fibrosis diagnosis usually clinical picture children have since the birth they have different manifestations. They can have delayed passage of meconium or meconium milius, or they can have prolonged jaundice. In infants, since the childhood, they have poor weight gain, chronic diarrhea, or if it is cystic fibrosis is manifesting with pancreatic insufficiency, then the pancreatic enzyme production is low, causing steatoria and recurrent respiratory tract infections, nasal polyps. So those things can be seen in weight loss. All those things can be seen in a child with cystic fibrosis. Usually, this cystic fibrosis is necessary to diagnose in bronchiectasis because the management slightly differs from a normal non-cystic fibrosis bronchiectasis when it compared to the cystic fibrosis. So uh, those are the features, those are the underlying conditions that need to be considered in bronchiectasis. One thing is nasty post-infectious in Sri Lanka TB, and then immunodeficiency, aspiration, foreign bodies, primary ciliary dyskinesia, cystic fibrosis, and bronchopulmonary aspergillosis. Those are the things that need to consider in a child present child who is investigating for possible bronchiectasis. So when it comes to now this question, recurrent otitis media is true. Recurrent otitis media can be seen in primary ciliary dyskinesia, it was cystic fibrosis as well as immunodeficiency. In any of these things, this might be there. Then chronic diarrhea with weight loss, particularly can see in cystic fibrosis. Delayed passage of, and also like if it is disseminated TB or something, also this chronic diarrhea and weight loss can be there. Anyway, it has a significance to etiology. Delayed passage of meconium is also true. That's meconium ileus could be manifested in cystic fibrosis, so that is also true. Maternal IV drug use, actually, I didn't find anything that's related to maternal drug use. IV drug use can later manifest as bronchiectasis, so that's I didn't find anything. I think it's not true. Long-term corticosteroids is a bit of a question because immunosuppression, immunodeficiency per se is there, but I didn't. I actually looked for this, but I couldn't find anything like specifically saying long-term corticosteroid use causing bronchiectasis. But it's a stem, kind of a stem that it's better to leave there rather than marking කියලා මට නම් හිතෙන්නේ. Anyway, I didn't find anything closer, anything specifically saying this long-term corticosteroid use causing bronchiectasis due to immunosuppression. I didn't find anything. Most probably wrong, but it's a stem that even if you leave it without marking or anything, that's also fine, I guess. So those are the things that we need to know regarding the etiological conditions that etiologies that causes a bronchiectasis. So for after that, the diagnosis usually to get the diagnosis, the sweat chloride test is done to exclude cystic fibrosis as a screen. Then HIV screening, immunoglobulin levels, if we suspect a primary or secondary immunodeficiency disorders. Bronchoscopy is indicated only if there's a clinical or some evidence of focal bronchiectasis is there, because then it usually narrow down the diagnosis to uh, something anatomically is there, no? So that is indicated for focal bronchiectasis. Then for TB, obviously gene expert, those things. And yeah, then for like this allergic bronchopulmonary aspergillosis, those things, IgE, those things, and this skin prick test, those things are done. And if the for these milk scans are done for children who have we suspect this recurrent aspiration pneumonia. Uh, yeah, those are the things we usually done in as an investigation wise. For bronchitis, we don't. I think we don't need to know anything about management a lot, but just the things that causes it and the workup that is usually done to diagnose, find out an etiology, those things are enough, I guess. This is stem E is a bit of a problem because I didn't find anything that say like long-term corticosteroid use causes uh, immunodeficiency strong enough to cause bronchitis scala. So it's if I found anything that says specifically no something, I'll send in the group. So the next question is, a 3-year-old with well controlled asthma is brought with a history of sudden onset of difficulty in breathing while playing with her sister. There's no history of fever or cough. On examination, respiratory rate is 60 with recessions and a saturation of 85. She showed poor response to 3 cycles of back to back nebulization. What is the most appropriate next step of management? So, this is something that I earlier mentioned. When it comes to asthma, there can be asthma mimics, or something that is with asthma that complicating something. Now, this child has a history of asthma, sudden onset of difficulty in breathing while playing with history, but there's nothing says about a stridor or wheezing, no, to get an idea where the obstruction is, whether it's upper or lower. Then there's no history of fever or cough, so there's nothing to say like there's an infective exacerbation, or there's nothing to say possible pneumonia, but obviously she is in respiratory distress and SpO2 is 85. Showed a poor response to 3 cycles of back-to-back nebulization. The most appropriate next step of management, uh, in this level, one thing that we can, with the history, we can't exclude one thing that we need to definitely exclude in this child is a foreign body aspiration, especially with the history of uh, a sudden onset of difficulty in breathing while playing. So one thing is a foreign body aspiration that's definitely need to be respiratory distress, and there's no response to the nebulization as well. Uh, so that's one thing. And the other thing possibility is, if even it is a very severe asthma and maybe there's a pneumothorax or something while playing, it's very unlikely, but other possibility is a pneumothorax. So either way, to diagnose, we need to do an X-ray. So in this child, an urgent chest X-ray is the most important thing. And if we suspect a foreign body aspiration, the other things that need to do is an urgent ENT referral. And also, this child actually needs an ICU reservation for this child. Even after, if the child goes into a surgery, definitely she needs. Uh, other than those things, yeah, those are the things that need to be done at the immediate level. Antibiotics, there's no indication to give antibiotics. There's nothing going on, no fever or anything. There's no sign of infection, so antibiotic is not something recommended. And ABG is also, ABG may be considered, given that there's a poorly responding with 60 minutes with recessions, she might be going into a respiratory failure if the exertion or the respiratory work is so much. But the thing is, before that, to make a diagnosis or to exclude the diagnosis, the urgent chest X-ray is necessary. So the most appropriate next step of management is urgent chest X-ray, I think, because this given the history, we cannot exclude a foreign body aspiration. Even with the acute episode of wheezing, always we have to consider the other possibilities of anaphylaxis, foreign body aspiration, and even a pneumothorax is possible. If there's fever, cough, pneumonia, so those are the other things we need to consider other than asthma. Even if the child has a history of asthma, those things need to be considered in a case of a poor response. So the next question, a 7-year-old girl presented with spasmodic bouts of cough followed by whooping for 10 days. She was diagnosed with a whooping cough and started on erythromycin. What is the most important reason for starting erythromycin? So when it comes to this pertussis or whooping cough, uh, it's a sort of a prolonged severe respiratory illness in usually children below 5 years the age group. Usually immunization is also done at that point. No, 7 years is a bit unlike bit of an odd age, but maybe the question is problematic. But it's a bit odd age to get pertussis. But the thing, if it is she's diagnosed now, it's caused by the Bordetella pertussis, as we know. And there are some other organisms also can cause a similar illness, but it is not not and the usually a child has like runny nose, some low grade fever, and occasional cough. And after that, what happen is episodes of rapid bouts of vomiting is there. Maybe vomiting is post-acute vomiting is there, and exhaustion after a coughing episode is there. So those are like the typical clinical picture. Now, when it comes to the whooping cough, there are three stages. Usually, it's a dragging illness. It can go on for like weeks. Starting from 1 to 2 weeks and go into resolution, but also it can go all the way up to like 3 months. So when in a classic illness, there are three progressive states. One state is the catarrhal stage. They are this first about 1 to 2 weeks, and then we get the paroxysmal stage where this paroxysmal episodes of cough occurs, and then after that it's usually go up to like 9 weeks, and then after that it go into resolution, the convalescent stage. So that's the usual symptom progression in the disease. But the thing is, it can go into other complications. It can go into superadded pneumonia, the secondary pneumonia, children, they can go into seizures and pneumothorax. So those are like some complications that usually need to know. And investigation wise, the culture is the culture is the gold standard. But now the PCR is there, and paired serology. Those things are actually available at the MRI. Uh, So management wise, management wise, what the things that we do is whether to admit the child or not. One, to admit as in any disease, usually the admission criteria, like if they're having persistent distress, and if they're unable to feed, seizures, or if there's any evidence of secondary pneumonia. So for those things, we admit the child. And there's some supportive care measures like bronchodilators, steroids. Those things are given, but the problem is uh, evidence. There's no evidence of actual benefit. Then for the antimicrobial antibiotic therapy wise, the choice is macrolides, erythromycin, clarithromycin, or azithromycin. And the thing is this: if we start the uh, as the macrolides, that means here erythromycin early, that means about at before 7 days of illness, it can actually reduce the duration and the severity of the symptoms, and also reduce the ongoing transmission. If it is give the macrolides in the early catarrh stage, that means like within the first week itself, again, it prevent the clinical progression of the disease. But if we give during the paroxysmal stage, as in this child, now that she has already gone into this spasmodic episodes of cough, no, that if we give at that stage, usually it does not change the clinical cause. The child will go on for a paroxysmal stage for a few weeks, and then she will go into remission. That does not change. However, when we give at that stage, what happens is the antimicrobials go and act on the bacteria at the nasopharynx. So it does not reduce anything, it doesn't do anything to the child at to the clinical progression of the disease, but it goes and reduce the transmission because it reduced the bacterial population at the nasopharynx at that stage, and it may eliminate even. And if we give the antibiotic very early, ideally before 7 days, if the child has not gone into this spasmodic paroxysmal stage of the cough, then it reduces the duration and the reduce the symptoms. But and also it reduces the transmission. But if we give beyond 7 days, or let's say in the paroxysmal stage, it does not going to do anything with the clinical cause of the illness of the child, but it reduces the disease transmission by acting on the bacteria at the nasopharynx and eradicating them. So in this child, disease complication minimizing is actually not done. Severity and duration of symptoms is true if it has been started earlier. But since it's at the paroxysmal stage, the proven benefit of starting erythromycin or a macrolide is to reduce the disease transmission. Usually, if the child is less than 9 months, 4 months of age, anyway, the child will be admitted. And after that, this is whooping cough is a notifiable disease on suspicion. It doesn't need to be confirmed case. It can be notified on clinical suspicion. And prophylactic antibiotics also, post exposure prophylaxis given for should be given to all the household contacts of the case and the high risk people and close contacts of the high risk case. Uh, Usually antimicrobial prophylaxis we give for 21 days. Within 21 days of onset of cough in the index case. So those are the things that we need to know about the whooping cough. Yeah. Basically, those things, it's nice to know like what are the early symptoms and the clinical course of the illness. There are three stages like that, and then possible complications, and then the what are the investigations that we do uh, to diagnose the condition, as well as supportively we do full blood counts, because there's an absolute lymphocytosis in most of these children. Usually it's very characteristic in the early catarrh phase, where can go up to like 15,000 to 100,000, and then we actually use that as an indicator to monitor. And the choice of antibiotic is a macrolide, erythromycin, clarithrol, or azithromycin. And the purpose of giving is if it is started early, to reduce the symptoms, the severity, duration of the symptoms, and to minimize the disease transmission. If it is given at the paroxysmal or later stages, it doesn't do anything with the cause of the illness, but it reduce the transmission. So that's the pretty much the summary. Then the next question is 2014 regarding childhood asthma. Cough is more pronounced in daytime. That is wrong. In the diurnal variation, usually it's worsen towards the night. Then allergic rhinitis is a non-comorbidity. That is true. The entire spectrum of atopic diseases, allergic rhinitis, atopic dermatitis, allergies, all these things are common, non-comorbidities. Chest tightness is seen in older children. That is true. Uh, because when it comes to these pediatrics, the symptoms usually change with the age as they try. Now, chest tightness usually it's a classic feature of asthma, shortness of breath, dry cough, this chest tightness, and difficulty in breathing. But chest tightness can be only expressed by older children. That is true. Poorly expanded lung fields are noted in chest X-ray. That is actually wrong, because in asthma it's an obstructive disease. Usually, in a milder cases, actually change in the chest X-rays. Even if it is change in the latter parts, it's not poorly expanded. Usually, they are hyper-expanded. IV salbutamol is used to treat acute severe exacerbations of asthma. True, not a very first line drug, but after the back-to-back nebulizations, steroids, magnesium sulfate, when those all those things do not work, ideally in an ICU setting, IV salbutamol can be used. That's also true. So wrong, true, false, true, true, false, and the last one is also true. Okay, the next question. 10-year-old boy with low socioeconomic status presented with low-grade fever, dry cough for 3 weeks. On examination, he is febrile, ill-looking, respiratory rate 40, area of bronchial breathing in right middle zone, and he was treated with, I think it's not IV, maybe oral, coamoxicillin and azithromycin, but no improvement. What is the best investigation to arrive at a diagnosis? So, poorly resolving pneumonia, if we say. Now, it's easily we can diagnose pneumonia in this child. Fever, uh, ill looking, respiratory tachypnic for a 10-year-old, 40 is tachypnic, and there's a bronchial breathing in the, there's a consolidation in the right middle lobe as well. And he has not responded to coamoxiclav and azithromycin, covering both gram positives and negatives. So, in our setting, in a poorly resolving pneumonia, one thing that always comes first is TB. Especially in this child, we see some clues. Socioeconomic status, low grade fever dragging on for 3 weeks, and ill looking. So these things point towards a bit of uh, strong suspicion on pneumonia. So when it comes to no, pneumonia, TB, sorry. So when it comes to TB, now out of the given tests, usually in this what we call SBR questions, there are things that we can uh, eliminate initially. Now mycoplasma antibody, not much, because one thing is already azithromycin is given and it has not responded, and anyway it doesn't causes this much of a typical picture, so that's out. Sputum culture, yes, ideally that's the gold standard in the diagnosis, but the problem is TB cultures take up quite a bit of time to come. uh, Earlier, like with the LJ medium, it's 6 to 8 weeks, I think. Now it's a little more faster, but still that's not. Then ESR is not diagnostic. It's not diagnostic for anything. It doesn't confirm towards anything. It's based in any inflammatory condition, so it will be anyway high usually. Then the thing that we use, the most sensible thing to do at this stage is a MAN2 to point the diagnosis towards it's screening test still as a screening, but it's a better test to diagnose to screen at this stage. Anyway, the thing is like MAN2 will be can be false positive and false negative in many conditions that you need to know a little bit, because now if especially if the child is very malnourished and immunocompromised, those things, in that cases actually the MAN2 can be negative without falsely negative also. But I think out of the investigations given here, for the diagnostic purposes and screening purposes, MAN2 is a better choice. So, a little bit about this poorly resolving pneumonia when it comes to if the pneumonia is not resolving, there are multiple things that we need to think about. One thing is whether there is a complication developing in the due to pneumonia. One thing is a parapneumonic abscess, parapneumonic effusion, empyema, or even if it's a lung abscess formation, then disseminated infection with multiple foci, or if there's a secondary infection is going on, and if the antibiotic resistance is there, and so those are like some of the things that we need to consider in unresolving or poorly resolving pneumonia. And another thing is, if there's immunodeficiency in our settings, TB, as in this case, and even maybe cystic fibrosis, primary ciliary dyskinesia, all those things should be considered in unresolving pneumonia. So at that stage, the choice of investigations that we go is, one thing is TB screening, and if it is pointing towards an immune deficiency, we can go with immune screening for the cystic fibrosis with sweat chloride test. And there are other investigations. If we are suspecting aspiration pneumonia, then the milk scans. So, and if we suspect focal unresolving pneumonia, maybe bronchoscopy due to a structural abnormalities in the lung. So that's how this investigation go in a case of a poorly resolving or unresolving pneumonia. So we consider if a pneumonia is unresolving by definition, if the pneumonia is persistent, even if we give the antibiotics up to 10 days, or if it is still worsening, or even after 3 months or 12 weeks, there's no radiological resolution at all. So those are the criteria that we use to diagnose an unresolving pneumonia. In this case, we don't know whether it is given for how long, but anyway, for 3 weeks, no. So we can take this as an unresolving or poorly resolved pneumonia. And then the line of thoughts usually go with the clinical picture to decide on what could be the possible reason for poor response. In this setting, if with the child with, especially with a low socioeconomic status, usually that is something we get, like if it is there in a question, we always need to think about TB, and there's like low grade fever, so those things, and especially in this child, there's no response to both cover coamoxiclav and azithromycin both, so that point towards a TB. So the other causes, like if there's only one antibiotic was given, and if it is the dose is not appropriate, maybe with the inappropriate regimen, or one possibility, another possibility is, if the fever is going on and on, one thing is it may be, there may be another infection going on, or the child may have gone into sepsis, or even antibiotic resistance, or maybe unusual organisms causing pneumonia. So those things will need to play. If there's a history of a child with like recurrent pneumonias going on and on with other infections since from the childhood, then we need to think about immunodeficiency. And then if a child has like recurrent history of choking or aspirations, or there's a past history of some sort of a neurological disease, there's a history of like CP. In those cases, we need to think about aspiration pneumonia. If there's a history like suggestive of like meconium ileus or anything, if there's a long ongoing history of poor weight gain, or they are difficult to thrive, or maybe like some gastrointestinal problems going on alongside with these respiratory conditions, and in those cases, we need to think about bronchiectasis, cystic fibrosis, those things. So that's how this we need to differentiate on different courses, or the investigations that we need to choose to investigate in a case of unresolving pneumonia. So the next question is, a 5-year-old girl born into consanguineous parents has come to clinic for poorly controlled wheeze with recurrent infective exacerbations. She produced copious amount of sputum after bouts of cough. On examination, she is emaciated and has finger clubbing. She has undergone a surgery for intestinal obstruction in neonatal period. What would help to diagnose the underlying condition? So now this is pretty much everything that we discussed earlier. 5-year-old girl. Consanguinity is very important to notice here, because the thing is, when it comes to cystic fibrosis, consanguinity is very important because it's autosomal recessive. It's not something that is very common in our setting, like in Asian countries, but it's the commonest life-limiting genetic illness in West, among genetic disorder among the Caucasians. So it has autosomal recessive inheritance. So consanguinity is an important point that especially strongly pointing towards cystic fibrosis in this child. So she has come with poorly controlled wheeze with recurrent infective exacerbations, produce copious amounts of sputum. So in cystic fibrosis, what happens is there's a the cystic fibrosis transmembrane regulator gene, this CFTR gene, which is located in the prostate. chromosome 7. And after that, what happens due to defective synthesis or the function of the ion channel, uh, this ion channel of the called CFTR, and what happens is ultimately it results to uh, dysregulation of chloride transport across the epithelial cells of mucosal surfaces, and indirectly it regulates the sodium and water conductance. So this dysregulates this sodium and water conduction and the secretory functions in the epithelial cells. So what happens? It go and affect mainly along the gland functions, especially exocrine glands in multiple organs. Uh, what happens is now decreased chloride secretion is reduced due to the mutation in the gene, and then indirectly it causes increased sodium and water reabsorption, and it causes uh, improper hydration of the mucous membrane. And due to the now the water has been more and more reabsorbed into the epithelial cells, and what's left is very hyperviscous secretions. So what happened? They start to accumulate in the respiratory tract. It can accumulate in the pancreas, GI tract, sweat glands, and any exocrine tissue in the body. So it's going to affect the respiratory tract, and also infect. So if it happens in the respiratory tract, what happens is the function of this secretions in the respiratory tract is mainly to expel whatever the inhaled organisms, inhaled pathogens, and particles. So that doesn't going to happen, and as a result, it's going to accumulate and cause infections. So they come with recurrent infections. And then another thing that happens is it also affect the gastrointestinal motility, motion, and then it can go into obstructions. In an infant, it go into meconium ileus, delayed passage of meconium, but also in a quite grown older child and in adolescent. On the other hand, they can also go into intestinal obstruction as well, and then it can go and affect in the pancreas. So in the pancreas, what happened? The exocrine pancreatic insufficiency is there. Now the enzymes can't come. As a result, there will be bulky stools, steatorrhea, chronic diarrhea, and they are especially alongside with the GI problems, they can go into failure to thrive, poor weight gain, those things. So they can manifest as like bronchiectasis as well. So uh, like in other countries, actually sometimes they do in like very high in prevalent countries, they include the sweat chloride the newborn screening. For the newborn screening, they have included the cystic fibrosis as well. However, for the diagnosis and screening, we include when we suspect clinically by sweat chloride test. So by the sweat chloride test, usually the if you take a report and see the cutoff level is 60, and by the genetic testing we confirm. So that's how we do. HRCT is maybe if we suspect the bronchiectasis, but in this child, not just the bronchiectasis. And the other thing is when it comes to in ped questions, if this saying is there on examination, if the child is emaciated, not up to the appropriate weight or height for the age, if that indicates, usually the diagnosis is not an acute one. It usually something that is going on for some time. And the other thing, finger clubbing also comes with chronic conditions in children. So With all these things, now the main suspicion is here is the cystic fibrosis. And for the cystic fibrosis, the test that is done is the sweat chloride. Now, HRCT is not something that is we need to do in this child, because the thing is there's a suspicion of bronchiectasis, but that's not the underlying condition. It's also a manifestation of the cystic fibrosis. So to diagnose the underlying condition, sweat chloride should be there. Serum immunoglobulins we do if there's a suspicion of recurrent infections. Now this child has infections, but there are some other features, especially the undergone for a surgery and those things, and consanguinity that points towards the cystic fibrosis. Emaciation can be still due to an immunosufficient children, also due to poor nutrition and increased prolonged increased demand. They also will be will be emaciated, but in this child, cystic fibrosis is the test that need to do. Okay, 2015, recurrent otitis media in children. Now, before going into this, in PED, the problem is now in adults, the only infection part that we see in RS is just the pneumonia. No? But in PED, the problem is there are these tiny parts like otitis media, tonsillitis. Those things are usually not taught in modules as well properly, but are the best place you can go and read, take a look again to just to get an idea. One thing is, there's this Sri Lankan guideline made for this, and that's actually pretty good to read up on the small parts, because sometimes they do question on these small topics as well in respiratory system, just not the pneumonia. This tonsillitis, whooping cough, acute otitis media, bronchiolitis. So now moving into acute otitis media, uh, in children, uh, now ear infections, usually the pathogens are, uh, we consider the pathogens we are worried are bacteria. The common ones are Streptococcus pneumonia, Haemophilus influenza, usually non-typable ones, and the Moraxella catarrhalis. So these are like the etiological pathogens, especially strep and Hib are the ones that we need to consider. Uh, the thing is, the usually the symptoms, maybe viruses also, sometimes these RSV and influenza virus also cause otitis media as well. Now, caused by strep pneumonia is absolutely true. Then we when it comes to symptoms, usually in children, one thing is there are some local and systemic symptoms. When it comes to the local symptoms in a small children, the only thing that maybe we can say is the irritable, or if the child is restless, maybe sometimes ear discharge and ear tugging or rubbing, that we can see. If a child is old enough, they might complain ear pain. And other thing is systemically they might have fever and maybe sometimes symptoms of an upper respiratory tract infection as well. So those are like the symptoms. And if infection is suspected, that horoscopic examination has to be done. So now we can see like this abnormal tympanic membrane, this opaque drum and bulging of the tympanic membrane, and maybe sometimes there may be purulent discharge. So those are the features that you can see. If there's an what you call effusion formation, there may be a fluid level in the Then the complication wise, the things that we need to know is the facial nerve palsies and mastoiditis and the sinusitis. And extracranially, they can go into meningitis and those things. So management wise, the usually acute otitis media actually sometimes they can go into resolution even without getting any antibiotics. Usually with the uh, course of like within 3 4 days they can actually go into like resolution as well. So analgesics also can be given, but the sometimes if the child is very well looking and there's a proper plan for follow up and facility to follow up the patient, then we can just wait and see actually if the child wait and see whether the child resolves. But always there has to have some sort of a mechanism to get the child back and ensure a proper follow up. And if to there's facility to begin the antibiotic therapy if the child worsens or fail to improve if we are going with a conservative management. Otherwise, if a child is having severe acute otitis media, either it is bilateral or unilateral, or if it's a very young child with bilateral disease, then we usually go with very young child with some with their infections, we go with antibiotics. So to start in the for the antibiotic, if otitis media is actually complicated or if the patient is immunosuppressed, then IV antibiotics also can be used. So the treat of the choice of the antibiotics that usually given for otitis media are oral antibiotics, not the ear drops. So amoxicillin can be given as a first line or coamoxiclav. Maybe in a penicillin allergy, a macrolide can be given. And for small children, a 10-day course, or for a large children, for more than 6 years old, we can go like for 5 to 7 day course is adequate. Those are the uh, basic management principles in otitis media. If in a case of like persistent effusions, recurrent otitis media, and if there's a facial nerve palsy and complicated with some mastoiditis or something, then ENT referral is required. And the other thing is the hearing assessment should be done in any child where the hearing is concerned by the caregiver, or if there's any changes in the language and speech development, or where there's a recurrent infection, or in a very young children, usually hearing assessment should be done. So those are the things that need to be done in otitis media. So when it comes to the acute otitis media in children caused by streptococcus pneumonia, that is true. Due to eustachian tube dysfunction, that also yes, true, due to the poor drainage. Can be complicated with middle ear effusion, that is true, glue ear. For the glue ear, usually the glue ear manifests with effusion. It can be asymptomatic as well. So the children sometimes can come with hearing difficulty, poor listening skills, speech delays, um, delayed language development, and recurrent or repetitive ear aches, recurrent upper respiratory tract infections, maybe behavioral problems. So those poor educational progress. So those things also can come. Those are also can be the manifestations of this middle ear effusions. So that is usually diagnosed with an oroscope, and then we do for the refer them for the hearing assessment and tympanometry. This where they do these graphs and everything, and then the management is different. If they have some sort of a risk of language or hearing or learning problems, then that should be they should be properly evaluated for everything, hearing, speech, and language disturbances, and then they need to be directed for the interventions if they are at risk. If there are no any risk for that such risk, then we can go for like conservatively watch for like 3 months, and if it is persistently there, then the child need to be referred and for the further evaluation. So those are the management principles in the this middle ear effusions. Give cloxacillin ear drops. That's not true. Usually we give oral antibiotics. Is prevented by breastfeeding. That is actually true. This is specifically mentioned in Lucas Madam's lectures. Regarding advantages of breastfeeding, these oligosaccharides in breast milk actually specifically reduce acute otitis media and other ear infections. That is true. So caused by streptococcus pneumonia, true. Due to eustachian tube dysfunction is true. Can be complicated with middle ear effusion, true. Give cloxacillin eardrops, false. Prevented by breastfeeding, true. So the next question, which investigation is the most appropriate to diagnose the underlying cause of a 9-year-old child's recurrent chest infection, poor appetite, frequent bulky stools, below minus 3 SD weight and height, and a deceased brother who had similar illness? Again, recurrent infections, poorly resolving infections, poor appetite, family history, frequent bulky stools, that means steatorrhea due to involving exocrine pancreas, and poor weight gain. In that case, we have to always suspect the in this child we have to suspect cystic fibrosis, and the diagnostic test we use is sweat chloride. Bronchoscopy not indicated routinely unless the problem in the chest is focal. If there's a focal, like only one place, particular lobe is involved, one particular segment is involved, then bronchoscopy is indicated. CT chest, HRCT to diagnose bronchiectasis, but that does not diagnose the underlying condition. HIV screening, yes, for no, not for this particular child. If the child has recurrent other infections and especially opportunistic infections, and if there's a family has some history recurrent blood transfusions, then HIV screening, yes. Anyway, the HIV screening is usually done in a child, this type of child, but that does not comes to the diagnosis. Serum immunoglobulin levels, immune screening should be done if we suspect immunodeficiency. In this child, the only thing that point towards the immunodeficiency is the recurrent chest infections, but no other infections or anything here. But the bulky stools and especially the family history, those things point towards cystic fibrosis, which need to be diagnosed with a sweat chloride test. Then a 6-year-old salbutamol and ipratropium back to back 3 times. She is still symptomatic with respiratory rate of 50, pulse rate of 150, saturation 92. What is the best management option? Now, in this, it's very clear. It's acute severe exacerbation already given, and the signs are very compatible. Increased respiratory rate for a 6-year-old true, 150 still high for a 6-year-old by pulse rate. Saturation is marginal, it's 92. Family history, and salbutamol and ipratropium back-to-back nebulization given 3 times. So that's has been done. So the next steps of the management, if the child tolerates child tolerates or a magnesium sulfate. If it's still not, uh, IV salbutamol, IV aminophylline, ICU admission. Then consider other investigations, ketamine, and sedation and intubation and ventilation. There's no point in giving salbutamol and niprotopium again. The ideally the best one is to start on steroids, IV steroids or oral steroids, but it's not here. Out of the options given, according to the stepwise according to the protocol, IV magnesium sulfate is the best one. Okay. Then I'm rushing a little because the time is also running out in the. Now, if you have any questions, let me know. Now, regarding peak expiratory flowmetry, sometimes they question a very little bit on these pulmonary function tests. Not always, very rarely they can. So when it comes to pulmonary function test, one thing we need to know is the peak flow measurement that is done by the peak expiratory flowmetry. This cylinder like thing. They ask the child to blow. So the interpreted now uh, interpreted with the height of the child. Now, this is actually true. Usually, we interpret the peak expiratory flowmetry is interpreted with not just with the height of the child, but with age, uh, sex, and race, as well as height of the child. There are like different curves to different curves to what we call it interpret. Then effectively used in a preschool child, no, that means like more than 5 years old. No, for this one to get to work, the child first thing need to obey the commands and produce a produce a good expiration. And for a preschool child, peak flow expiratory flow metric cannot be done. Used for home-based assessment of asthma control. For that, we can actually use. Then we can measure this reversibility and all these things. Average of the 3 readings is taken. That is wrong. We get 3 readings and we get the largest of it. Highest one is the taken, not the average. Best assessed in the stand in position. That is also true. We get the child to or the person to stand and then we ask them to blow. So that's one thing. We that's regarding the peak expiratory flowmetry. And another one thing, flow volume curves and bronchodilator reversibility measurement. For the flow volume curves, that means the spirometry. For spirometry as well, the child need to produce a blow and they need to obey the command. So that is also good for all the children and also asthma adults investigations in the adults asthma. Spirometry parameters are also influenced by this height, age, ethnicity, race, and the sex. There we get a curve. Then other things are this impending oscillometry and oscillation techniques. Those are to measure the airway resistance. So those are the things that usually this pulmonary function test that we need to know. So here interpreted with the height of the child, we get the the child? True. Effectively used in preschool children? No. Used for home-based assessment? Wrong. The highest one taken. Best test in stand-in position? Yes. True. Then 18-month-old girl was admitted with sudden onset noisy breathing in the middle of the night. She has a history of an upper respiratory tract infection with dry cough for 1 day duration. On examination, she was afebrile but anxious. There was a high pitch respiratory sound in inspiration. So this is again what we called stridor. So when it comes to stridor, uh, the two distinct things down, the usual questions that we get is either acute epiglottitis and laryngotracheobronchitis. Now, to differentiate between those two, we need to now 18-month-old girl. Here, noisy breathing, and there's a high pitch inspiratory sound in inspiration, that is inspiratory stridor. There's an upper airway obstruction, and she has a history of what we call some sort of a respiratory prodrome. So when we differentiating this between these uh, acute epiglottitis and tracheolaryngobronchitis, one thing is the one major thing that we see is usually in acute epiglottitis, children are very ill, febrile, toxic, uh, and the otherwise in the laryngotracheobronchitis, children are usually not very that ill. And the other thing is these children are this in laryngotracheobronchitis, you have some sort of a viral coryzal symptoms or upper respiratory tract symptoms, and usually it occurs over few days. The symptom progression occurs through few days, but in acute epiglottitis it can progress in like just hours of time. And these children have in laryngotracheobronchi in acute epiglottitis, these children have characteristic this tripod position, and since they can't swallow their saliva, they have drooling of saliva pooling in the mouth. So those are the clinical features that we need to uh, differentiate in between epiglottitis and laryngotracheobronchitis. Now, in this child with an 18 month, the age is also compatible with with a history of respiratory tract infections, not a toxic ill child, and with just a stridor. So this is laryngotracheobronchitis. Bronchiolitis is not very obvious, not a good diagnosis because there's nothing, no lung signs or anything, and there's no evidence of lower respiratory tract problem. Foreign body inhalation, usually you will see these features are almost confined. Sometimes these features can be confined to one side, and there's a typical history. Usually, it's not there. Then an 8-year-old girl presented with difficulty in breathing, chest tightness, bilateral reduced air entry in lower zones. The diagnosis was made as acute severe asthma, and she was nebulized with salbutamol and ipratropium 3 times back to back, but the response was poor and the heart rate was 140. So the next management option is, as we discussed, uh, now the back-to-back nebulization is not sufficient. So the next thing is magnesium sulfate. Actually, if there was corticosteroids, that comes prior to mag sulfate. Okay, 2017. A 5-month-old baby with coryzal symptoms and low-grade fever presented with shortness with cough and shortness of breath. On examination, there is bilateral fine crepitations. So with the usually the peak, the diagnosis is five for a 5 month old. This could be mostly bronchiolitis. The peak incidence usually occur in 3 to 6 months, but it can be like widespread distribution is there by age wise, but that's the usual one. And the etiology wise, usually bronchiolitis is most commonly caused by RSV, and it starts with coronal symptoms, most probably due to some sort of a viral infection and in the upper airway, and then virus spread all the way lower down to the bronchioles. So it causes inflammation and the obstruction in the small airways, and the obstruction is more prominent in the expiration. So infants usually show this lower airway involvement about few days later the upper airway symptoms. Now, when it comes to bronchiolitis, uh, there is also something what we call severity assessment in bronchiolitis is also there. So for the bronchiolitis is also as same as asthma. There are some criteria that we use to differentiate whether it's mild, moderate, or severe. So that's his behavior in the respiratory rate, accessory muscles, cyanosis, saturation, feeding, and if there are any apneic episodes. Now, if the child is very lethargic or if they are very irritable and the respiratory rate is very high and there is accessory muscle use and the oxygen saturation is low and there are increasing of frequent apneic episodes without breathing and difficult to feed, then we consider it's severe. And usually now Chaturangana sir hema hariyata ahanama me like indications to admit in bronchiolitis. One thing is difficult to feed. If the mother is not able to identify whatever a deteriorating child, and if there are some significant risk factors for a serious illness like past history of respiratory diseases, congenital heart diseases, immunosuppression, uh, faltering growth, and very premature children. So, though if there are some risk factors like that, and if they are not difficult to breathe, if they can't maintain a good saturation without oxygen, as well as if there's worsening breathing, and if the the social circumstances are poor and they don't have access to a medical facility, immediate medical facility. So under those circumstances, we can admit for bronchiolitis, and usually routine investigations are not required. And the treatment wise, humidified oxygen given via nasal prongs to maintain a saturation more than 92. After that, for fluid and nutrition, small oral fluids can be given. Nasal suction is not routinely done. Chest physiotherapy, those things are also not routinely done. Specifically for selected cases, antivirals can be used, but otherwise, the mainstay of management is observation and monitoring. There's nothing to do with nebulization or steroids, and with hypertonic saline also for an uncomplicated case. So just the mainstay is observation and monitoring until the illness resolves. Usually, most of the children fully recover from bronchiolitis, and only a small proportion of people go into complicated, long-lasting illness that is like bronchiolitis obliterans. Only a small number of people. If they had like very severe illness, there's a high chance they go into a longer illness. Okay, that regarding the bronchiolitis. So those are the MCQs we have. So I tried to cover pneumonia, TB, bronchitis, recurrent, especially they question on this recurrent chest infections, asthma, and yeah, asthma, these small topics like otitis media, those things. Yeah, those are the things that were asked in the question. There is no detailed question on SAQ. So in an SAQ discussion, I'll try to uh, do some SAQs with this commonly frequently asked SAQ topics. They have sometimes even asked about this like poorly controlled asthma also. Okay, those are the questions we have. I took about 2 hours. If you have any questions, you can ask. तीक्ष्ण नयनांग एन्करमु
I think we can end, Mithun.
Yeah, okay.
Thank you.
Thank you guys for joining.
Thank you.
Good night.